So yeah, I have no financial disclosures. I'm going to get right to it because we have a lot of ground to cover. We do have objectives, but I'm going to skip those so we can talk more about the good stuff. So we have a problem with vertigo. What is the problem we have with vertigo? The main thing is that we are scared of missing a dangerous cause of vertigo. And the most common dangerous causes of vertigo are the ischemic, or at least the posterior circulation stroke syndromes. Ischemic stroke, hemorrhagic stroke, posterior circulation TIA, and vertebral artery dissection. And we haven't been taught, we're not very good at doing nystagmus assessments. We don't really know how to look for it, how to describe it, how to interpret it. We've heard about things like Dix-Hallpike and the hints, but maybe we're not sure who should we be doing it on and how do we do it and how to interpret it. So you add all that up and you've got a lot of uncertainty and fear, not only of missing the dangerous causes of vertigo, but just seeing the benign causes. We're scared of seeing them because we're not sure how to diagnose them for sure. So when we compensate for that by doing too much imaging, unwarranted imaging mostly. And the other odd thing is that for some reason, even despite the fact that Epley's been around for 20 years or more, we're very slow to embrace using the Epley for BPPV, even though it's the treatment of choice and it only takes a few minutes and has one of the lowest number needed to treat in all of medicine. And then there's this. This is all the causes of dizziness, vertigo that I found in a journal that had about 10 different articles. And this is all the things I mentioned. The ones in red are the more classic vestibular disorders, but there's over 100 causes of dizziness, vertigo. That scares us too. But do we really need to know all those causes? I would say no. We don't need to be vertigo experts. When my colleagues ask me to help them with vertigo, they don't say, Hey, Peter, do you know any approaches that breaks vertigo up into 4 or 5 different categories and then parse them down to 25 different diagnoses? They say, just tell me what I need to know. Because you only have so much mental real estate in your brain for vertigo, and I don't want to clutter it up too much. And the other thing is the way to teach someone nothing is to teach them everything. If I taught you everything that you need to know to be a vertigo expert, you wouldn't be an expert or competent. And I want you to be vertigo competent. The first thing to become vertigo competent is to first screen for the posterior circulation stroke syndromes, screen for badness. And once you do that, the next thing is you should be able to confidentially rule in a benign cause so you can rule out a dangerous cause. So if you rule in a BPPV or vestibular neuritis, it means you don't have a stroke. So in order to do that, you have to know which bedside testing to do and how to interpret it. So my big 3 approach is basically leading the clinician who doesn't have a great interest in vertigo, doesn't see them all day, every day, lead them how to make lead them as clearly and straightforwardly as possible to diagnose BPPV, vestibular neuritis, and cerebellar brainstem stroke syndromes. And what it does is, as I mentioned, you screen for features of badness first, then you use evidence-based testing to rule in BPPV, vestibular neuritis. And if you do this, I think you will decrease the amount of diagnostic testing you're doing. You're going to decrease the amount of time the patient spends in the emergency department, and they're going to be happier because you're going to know how to cure half of them too, using just a couple of minutes of doing the Epley maneuver. Of course, it can't identify all the different causes of vertigo. There's real vestibular disorders I would like you to know about: vestibular migraine, Meniere's disease, perilymph fistula, which I've never seen, but it would be nice if you knew how to do all those things. But I think that might be a little ambitious. And also, all those conditions are not really time sensitive for diagnosis and treatment. I mean, nobody ever went home with a vestibular migraine and had a bad outcome. They may not have been treated properly, or maybe be over-investigated, but nothing bad happened to them. So if you see people who fall out of the big 3 categories of diagnoses, you feel free to refer them on to whoever your local vertigo experts are. And the other thing I don't cover is all the other bread and butter emergency medicine topics that are serious, like if somebody presents with a MI with dizziness or PE or carbon monoxide poisoning, you should be able to identify those. But I don't think you came to this lecture to help you find out that if you have chest pain and ECG changes and dizziness, you don't need to have a Dix-Hallpike test. So what I did devise is a table that outlines and this will be in Tintinelli's next edition, outlines the conditions of BPPV, vestibular neuritis, and cerebellar stroke, the characteristic findings you find, the presentations, what tests to do, how to interpret the tests, and whether you need imaging and what kind of treatment is necessary. And the second thing I have is a flow chart which helps you assess, this is the initial assessment of the undifferentiated dizzy patients, vertigo patients. So the first thing you'll notice at the top is that it says to screen for neurologic symptoms that are present or were present. So we'll just screen in or move in on that, zoom in. So if they have neurologic symptoms that are present or were present, see below. So we're talking about normal stroke symptoms like weakness of the arms or legs or paresthesias, and then the more posterior circulation symptoms like dysarthria, diplopia, dysphagia, dysmetria, dysphonia, or if you do see spontaneous vertical nystagmus. So that means you're just looking at them and you're seeing vertical upward or vertical downward, not part of the Dix-Hallpike test, but just vertical nystagmus. That's also concerning for a central cause, and you're going to need diagnostic imaging and referral to specialist care. Then the other things that are on there are if they have sustained significant headache, then you can be worried about something like a cerebral hemorrhage. If they've sustained significant neck pain, you're going to be worried about vertebral artery dissection. And the last thing on that little list is if they can't walk or they can't stand, you've got to be concerned about a central cause. Okay. People with vestibular neuritis, they don't want to get up and walk. You have to sometimes coax them, come on, get up, and then they can actually walk back and forth. But if they can't walk or stand, then you've got to be concerned. And the last thing is, on the top of that slide, it says if the symptoms are or were present. And that's the reason why it says or were, is because if you had a posterior circulation TIA, most of them are going to have something like diplopia or dysarthria or some weird arm thing going on that'll make you think this is not vestibular neuritis. So we'll just move through some cases. And first case is of an older woman who's getting about 15 seconds of vertigo when she gets out of bed, when she lies down in bed, and when she rolls over in bed. And she screens negative for all that badness that we just talked about. So one of the myths that some people hold is that if you move their head and it makes it worse, if they move their head and it makes it worse, it must be a peripheral vertigo. That's not true, because all vertigo gets worse when you move your head. If you take somebody with a cerebellar stroke and you sit them up, they'll go, oh, whoa, I got real dizzy there. That doesn't mean, oh, you've got BPPV. It doesn't work like that. So the case one, woman who does have vertigo when she rolls over, gets out of bed, lies down in bed, she has no spontaneous or gaze-evoked nystagmus. Now we have to talk a bit about nystagmus, which is painful, but we'll get through it. The first thing is, of course, that the direction of the nystagmus is defined as the fast component. So if these are my eyes, this is nystagmus to my right, horizontal nystagmus, okay? And then you can have vertical, that's vertical downward nystagmus, and that's rotatory to the left. And you can have a combination as well. And when I say spontaneous nystagmus, that's the nystagmus you see when the person's just looking straight ahead. That's called primary gaze. And then you ask them to look off to the left or the right and see if they see nystagmus then, and you see which direction it's going. And when you do that, a lot of people I'll see them look at my finger here, look at my finger over there. When you have them look at your finger, you're asking them to fixate on your finger, and fixation can suppress nystagmus. So it's better to remove fixation some way. The fancy vertigo people have these Fresnel goggles and infrared goggles, all sorts of things, but you can just take a piece of paper and just put it, have them say, look over there, and then take a blank piece of paper beside their head and say, look through that piece of paper as if it's not there. And then you might see nystagmus that you wouldn't see if you didn't do that. And the other thing to be careful of is that you don't see, if you see end-gaze nystagmus, know that's a normal variant. End-gaze nystagmus is when you have them look way off, and then you might see a few beats that stop, or they might continue, and they look the other way off, and then you see little beats. If you're just seeing that, you're not sure if it's pathological or end-gaze, just have them move in a bit. If it's still there, it's pathological. If it's gone away, that was end-gaze nystagmus. That's just a factor of you having to look way too far, and it's a normal variant. So this lady has a very clinically distinct phenotype. It's different than the other things that we're going to talk about. It's a short episode of vertigo, typically rolling over in bed, getting out of bed, lying down in bed. And so we always said she's screen negative. Is she having many hours or days of ongoing continuous vertigo or nystagmus? Nope. So let's go over here. Short episodes, we'll focus in here. Short episodes lasting less than 2 minutes, initiated by head movement, no ongoing continuous vertigo, spontaneous or gaze-evoked nystagmus is absent. So what do? Dix-Hallpike testing. Do not do the HINTS Plus testing in these patients. So I'm not going to go through how to do the Dix-Hallpike test. I have videos on YouTube, and if you're attending the workshop later this morning, we'll go through that. But here's this lady's Dix-Hallpike test, and we're testing her downward ear, the left ear, and we're looking at her right ear, right eye mainly. But so nothing happens the first couple of seconds. That's the latency. Now we're seeing the nystagmus, and if you look at it, I don't know how well it's showing up, but she's not. If you look at her pupil, it's not going horizontal. It's going vertical upward. And she has this little slit. I'm going to show it in slow motion in a second. She has this little slit on her iris right up there, and you can sort of see how it's torting towards the downward ear. The whole eye is rotating towards the downward ear, and her pupil is going up, up, up. It's vertical upward. That's a classic positive Dix-Hallpike test. In fact, the BMJ asked me if they could use this video for their teaching tutorial. So that's a classic positive Dix-Hallpike. They've got BPPV. Here's another one. This guy, when he looks towards his downward ear, it's more rotatory. You can tell that by looking at the vessel's eyes. Now when he looks upwards, it's more vertical. I show this in slow motion as well in a minute. So when he looks towards his downward ear, it's more rotatory. Now I'm not moving his head. I'm just asking him to shift his gaze, and it becomes more vertical. So more rotatory. See, look at the vessels on his conjunctiva. You can see how his eyes are rotating. When he looks upwards, it becomes more vertical. That's another feature of BPPV, and this is a classic positive Dix-Hallpike as well. So another myth is that I've shown these videos to people, and they go, oh, vertical nystagmus, that's bad. But as part of the Dix-Hallpike test, you expect to see it. If you see it, again, spontaneously, it's a different story. Okay, so positive Dix-Hallpike is almost always one-sided. You can get both sides, but not so common. Usually there's a latency of 3 to 15 seconds, sometimes a little longer. That means nothing happens the first couple of seconds. Then they grab the bed, they go, and then their eyes start moving in a crescendo, decrescendo pattern. And sometimes it's only 5 seconds, sometimes it can be a minute or a little bit longer. And you see vertical upward rotatory nystagmus towards the downward ear, which is the affected ear. And again, if you see this, there's no mimics of this. It's not a brain tumor, it's not a stroke, it's BPPV. And if you see that, again, the treatment is the Epley Maneuver. Now, who do you do a Dix-Hallpike test on? You do it on people who sound like they could have BPPV. So you don't want to be doing it on people who sound like they have something else. These people have short episodes. As I mentioned, they can also be when they bend over or when they look up like this, I can bring it on. And it doesn't last for a long time. Imagine spinning yourself around 8 times and then stopping. You go like, oh, I'm spinning, I'm dizzy, oh my God. And after about 15, 30 seconds, you're like, I'm not really spinning anymore, but do you feel back to normal? No, you feel a little off, you feel a little nauseated and sweaty. And that's why sometimes patients will say that they were dizzy for 5 or 10 minutes. But we say, well, how long were you that intense spinning lasting for? Oh, half a minute. That sounds more like it. And again, they don't have any spontaneous or gaze-evoked nystagmus. And it's more common in older people and more common in women. But I've certainly see young men and people in their 30s, and it even happens in children. The Epley Maneuver, again, is the treatment of choice, and we're not going to demonstrate that now, but there's videos on the website and at the workshop. We'll go through it. And of course, the Epley Maneuver, it really does work. If someone tells you it doesn't work, they're not doing it on the right patient or the right way. If you do it the right person, the right way, 80% of people, boom, they're fixed. If you do it a second time, you're up to 90, 95. What I do is I do the Epley Maneuver, and then I leave them sitting up for 15 minutes. I go see another patient, I come back, I retest the same positive side, and if it's negative, they have no nystagmus, then they're cured, and I send them home. If it's still symptomatic, I'll repeat the Epley Maneuver, and if I wait 15 minutes, repeat it again, it's still positive, I'll say, remember what I'm doing here, because you're going to do this at home twice a day until you're cured. The number needed to treat is one of the lowest number needed to treat in medicine, and there's really been no reported serious outcomes. So these patients, they don't need imaging. If you look at the statistics of the studies that have been shown, typically 30, 40% of people with BPPV get a CT scan. It's not necessary. It should be 0 or close to 0. And the medications don't benefit because it only lasts for 30 seconds. And if they're cured, they don't need any follow-up. If they're not cured, you can follow them up with whoever you like to send your dizzy patients to. Now that was the easy part. This is a little bit difficult, and your heads might explode when I talk about this, but there's not only one kind of BPPV. When people say BPPV, they're talking about posterior canal BPPV, which is the most common type, but there's another kind. So if you do a Dix-Hallpike test and you see nothing when you do it, even though it sounds just like BPPV, and you do it, nothing happens, or if you see this, then you have to think about something else. So this is kind of an awkward Dix-Hallpike done by somebody who wasn't good at it, but nothing really happens at first, and then that's not vertical upward nystagmus. That's not rotatory towards the downward ear. That's the pupil is going horizontally. You're seeing horizontal nystagmus. That's not a positive Dix-Hallpike. That is suggestive that the patient might have horizontal canal BPPV. So I'm just going to tell you what you need to know, not too much. And in my algorithm here, I do say that if you have a negative Dix-Hallpike or atypical response, consider other diagnoses. The most common diagnosis will be that they have horizontal canal BPPV. So I used to not talk too much about it, but it turns out I do see a lot. Probably 30% of my patients with BPPV have it, and there's been studies showing up to 40% of emergency patients will have horizontal canal BPPV. And again, it'll be either negative on both sides or you'll see horizontal nystagmus. So you have to do a different test, which I've got a video on YouTube. It's 8 minutes long. Shows you how to test it, how to interpret it, and how to cure it with a different maneuver called the Epley Maneuver. You can't do an Epley Maneuver on somebody with horizontal canal BPPV. And you are going to see, how many people do you think, now that I've said this, you think you've seen horizontal canal BPPV? Anybody? Yeah, there you go. So it's not like it's that rare. Okay, now we're going to move on to case 2. This is a guy for a day and a half having vomiting, vertigo, worse with head movements, trouble walking, screening negative for all the nastiness. And does he have nystagmus? Sure he does. The primary gaze, you're seeing some left beating nystagmus. Then when he looks to the left, it becomes more intense and increases in frequency. Then when he looks to the right, it's still beating to the left. It's not changing direction. It's unidirectional nystagmus. This is another same clip of the same guy, or different clip of the same guy. So, and there's a bit of a rotatory component too. You can tell by looking at the vessels on his conjunctiva that his eye is rotating a bit towards his left. You can see them kind of moving up there. And so this is a very typical pattern of a peripheral pattern, typical vestibular neuritis. It's unidirectional. It doesn't change direction based on which way he's looking. That's very typical. So we have this guy, and he's not a short episode. He's one of these guys up here, long episodes. So we'll zoom in on that. Many hours or days of ongoing continuous vertigo, worsening with head movement, has spontaneous and gaze-evoked nystagmus. They don't have to have both, but and then what you do is the HINTS plus testing. And you don't do the Dix-Hallpike test on a patient like this. You've probably heard of HINTS. Now I'm going to talk to you about HINTS plus, which isn't too much more. The HINTS plus is just the usual HINTS thing, looking at the nystagmus, test of vertical skew, head impulse test, but it's adding a bedside test of hearing in order to pick up ICA strokes. And the ICA is the anterior inferior cerebellar artery, and if you have an infarct in that area, you'll infarct part of your cerebellum, but it also has a little branch called the labyrinthine artery, which will infarct your labyrinth, so you'll lose your senses of hearing and your senses of balance. That's where they reside. So then you'll have a hearing loss, and you'll also look like a peripheral lesion. So the bedside test of here is just, can you hear this? Can you hear that? And if they go, no, I don't hear that very well at all, and that's a new thing for them, and that came on at the same time as their dizziness and their nystagmus, then that's concerning for an ICA stroke. So that's what the HINTS plus part is. So our patient that we saw earlier had unidirectional nystagmus. We saw that right off the bat. I'll tell you, he didn't have any skew deviation. We'll talk about that more later. And then he also had no new hearing loss. So that leaves us with the head impulse test. And it's probably the most difficult thing to do and interpret, but it's not that hard. And it's looking to see if you can demonstrate that they have a nerve problem. Because the basic differential for the HINTS plus testing is, do they have a stroke or do they have vestibular neuritis? And the most powerful tool you have is to look for the abnormal head impulse test that says, oh, look at that. You've got abnormal head impulse test, you have a nerve problem, you probably don't have a brain problem. You're not having a stroke. So here's a lady that I'm testing here. When I first move her to the right, it's normal. Her eyes are stay fixed on my nose. When I that way, you see it. When she turned the other way, her eyes took. I'll just show you maybe one more time. Her eyes turned. It overshot my nose and took 2 turns coming up right here. 2 turns to get it back. That's an abnormal head impulse test. That means she probably has a nerve problem. Here's another old guy that he said he had to wait. When he turned his head to the right, he had to wait for his eyes to catch up. That's what it's called, a catch-up's a cat. So here's normal to the left, and turns his eyes to the right. His eyes do a little catch-up's a cat. You guys seeing that? You need it one more time, or you got it? We've got one more coming up with our patient that we saw earlier with all the nystagmus, and his head impulse test is going to be abnormal when he goes to the right, which I do the first time. So the first time is going to be abnormal here, catch-up's a cat. Turn the other way. He's got so much nystagmus. You see some nystagmus there, but no real catch-up's a cat. And then one more time, see, abnormal catch-up's a cat, abnormal head impulse test. This guy has a nerve problem. So again, this is the counterintuitive thing, that an abnormal finding is reassuring, because it's demonstrating that you have a nerve problem and you probably have vestibular neuritis. And it's important that you document all 4 of the elements of the HINTS plus testing. You have to say that it's unidirectional nystagmus, no vertical skew, an abnormal head impulse test, and no new hearing loss. Then you can say, wow, this guy's got HINTS plus peripheral result. He likely has vestibular neuritis. I can send him home. Now, vestibular neuritis, the treatment is mainly symptomatic. If they're vomiting a lot, you give them your favorite antiemetic for a few days, not very long, not more than 3 or 5 days. Steroids is controversial. Imaging, if you've screened them out for all the neurologic signs and their HINTS plus is a peripheral result, you don't need to image them. And the follow-up, you can, wherever you'd like to follow these people up with. They get better like a Bell's palsy, basically. So the last case is of a 78-year-old woman with vertigo who's, she actually fell on the floor, was lying on the floor for a couple days. She couldn't get up. Head was spinning, vomiting, didn't have any headache. No, called the ambulance to come. And she had normal strength. And did she have nystagmus? Well, let's have a look here. So when she looked to the right, you can see little beats nystagmus to the right. I show it again. A second, you can see the nystagmus to the right. And then when she looks to the left, you see nystagmus is now beating to the left. So it's changing direction. It's bidirectional nystagmus. That's bad. There's no peripheral cause that will do this. So we know already she's HINTS plus central. So again, she's not having short episodes, she's having these long episodes. We zoom in there, we do HINTS plus testing, Dix-Hall-Pike test, not indicated. And her test of skew is normal. When you see it, she has so much nystagmus, it's a little difficult to tell, but she also has a little horizontal movement. Horizontal is not skew. Skew means slant, so it's either diagonal or straight up and down. Horizontal, bit of horizontal movement, left, right, is not considered to be an abnormal test of skew. Now here's a guy who does have an abnormal test of skew. If you look, as I take my hand away from his right eye, you'll notice that it'll move medially and diagonally upward. And the other eye moves diagonally downward. So it moves, see how it moved upwards diagonally and downward a little bit and then upward. This is an abnormal skew, and this guy was having a stroke. And the head impulse test in Our Lady with all the bidirectional nystagmus, it was totally rock solid. It was normal. Now you guys probably have all normal head impulse tests too, but she's having vertigo and nystagmus. So we're looking to see, do you have vestibular neuritis? And we can't find it. So that's where we get worried. She has a normal head impulse test, even though she looks like she should be having vestibular neuritis. She's got nystagmus and vertigo. So that's why the normal head impulse test is worrisome in this situation. And her finger rub test was normal. So as opposed to the peripheral result where you have to have all 4 a certain way, if you have any of these, if you have any of bidirectional nystagmus, vertical skew deviation, a normal head impulse test, which is again counterintuitive, or a new hearing loss, then your HINTS plus central result, probably a stroke, need imaging referring to specialist care. And again, just to drill in the fact, a normal head impulse test in HINTS plus exam is worrisome because you would you would hope to see a abnormal head impulse test to reassure you that they have just vestibular neuritis, but they don't. And the other thing is, when do you, I don't know if you've heard any of your colleagues say, yeah, I did the Dix-Hallpike and the Hintz test on them, they're both negative. You shouldn't be doing that. You shouldn't be performing both of them at the same time, because to do the Dix-Hallpike test, you should be doing on patients who have short episodes of vertigo that then they don't have any nystagmus when you examine them. And not part of the Dix-Hallpike test, but sort of when you're going to do the Dix-Hallpike test, initially you don't see any nystagmus, then you do it, then you see the nystagmus. Well, with Hintz plus testing, you do it on people who have spontaneous nystagmus and they have ongoing continuous vertigo. It is true that sometimes people with, BPPV can present a lot of different ways. I've had people who I'm working with and they have BPPV. I've had other people come by ambulance because they can't get out of bed. So sometimes they feel a little off, not completely normal, but they're usually walking around. We're talking about the BPPV. So basically, don't do the Dix-Hallpike and the Hintz exam on the same person. You shouldn't be doing that. So I want you to become vertigo competent. I want you to be able to screen for badness, like they can't stand, they can't walk, they have focal stroke symptoms, they have the posterior symptoms like the deadly Ds. If they have headache, neck pain, vertical nystagmus, then they need imaging. If they have the short episodes with no nystagmus, then you can do the Dix-Hallpike, and if it's a positive Epley or positive Dix-Hallpike, you can do an Epley. If they have hours or days with nystagmus, then you do Hintz plus testing, and most of them can go home without imaging. But if your initial screen is positive or your Hintz plus testing is giving a central result, then you need to image them and refer them. And if you see patients that aren't fitting in this diagnosis, either read up on them and figure out what they are or refer them to follow-up. They're probably safe for discharge. Oops, I went backwards, sorry. And that's basically all I'm going to talk about. Again, if you just search for my name in YouTube, you'll see this little guy here, and all my little videos are on there, and there'll be new ones coming up as well. And I'm happy to, if you want to email in any questions, I'm happy to answer any questions or hear any comments you have. And with that, I'll stop and take any questions you might have.